Hi, this is Colleen Parsons with Abdominal Assessment Part 3. You'll need your stethoscope. As we're not going to do parts of this, you won't need a ruler and you won't need a skin marking pen. As with all assessments, you start with inspection of the abdomen. You're really looking at the contour. And there are 4 specific contours that are mentioned in your Jarvis text. You're looking for symmetry. If you shine a light across the abdomen towards you or shine it lengthwise across the person, you should see it as symmetric bilaterally. Oh, here's the slide. Inspection of the abdomen includes looking at the umbilicus or umbilicus. People say it in different ways. You're looking for a hernia. You're looking for inflammation. You're looking to see if it's inverted or any sign of discoloration. You're looking for foul-smelling fungus sometimes get into the umbilicus and really creates a nasty smell. It shouldn't be red or crusty. And as far as you want to also record piercings. I don't think we talked about that with the head and face, but you do want to record all of your piercings that are obvious. Surface of the skin should be just like skin should be everywhere else, smooth and the same color throughout. No indication of dehydration. You're going to be looking for any stretch marks, striae. They're often pink or blue, and they turn silvery white over time. There are a couple different reasons for the striae. One is pregnancy. Another is fast weight gain or a fast growth. Medications can cause a rapid weight gain, especially psychotropic medications. Normally, you won't see lesions, but you may see some healed scars or surgical scars. You also may see rashes or look particularly carefully at any moles or nevi that you see. And scars, make sure you write down all of the scars and how they occurred. You're also going to look, you're still on inspection, you haven't even touched the patient yet. You're going to look for any pulsations that you might be able to see without touching the patient, especially in the area of the aorta, beneath the skin, in the epigastric area. You're going to look at hair distribution. Is that a common pattern of pubic hair growth that is normally seen? And you're going to see if the patient is guarded or is having difficulty with respirations or anything along those lines. Then you're going to use your stethoscope to listen to the bowel sounds and the vascular sounds. This is done because this is the only time you use auscultation before you do percussion. And that's because percussion will increase peristalsis and it will give you a false interpretation of what the sounds are doing. So you want to use your diaphragm on the patient in the 4 quadrants of the abdomen. If for some reason you're not hearing bowel sounds in that 1 minute space, you need to listen for 5 full minutes, and you need to actually set your watch before deciding whether or not the bowel sounds are absent. So you're looking, are they high-pitched, are they gurgling, are they cascading sounds? And you would learn this over time, but for right now, you're just listening for any type of bowel sounds. Once you listen to enough abdomens, Then if you hear something different, then you can ask somebody else what their opinion is and go from there. You can judge if your bowel sounds that you're listening to are normal. Are they hyperactive? Are they hypoactive? So certainly hearing 1 or 2 bowel sounds in a 5-minute period would be hypoactive, right? Hyperactive means you're hearing an awful lot of them, and normal would be an occasional bowel sound, probably 2 or 3 in a minute. As you listen to the abdomen, you note the presence for any other vascular sounds or bruits. You'll need to use firmer pressure over the aorta and renal arteries, iliac arteries. So you'll use the diaphragm and you'll have to press into the stomach, into the abdomen in order to hear those sounds. Well, there's a good diagram in the book, hopefully there'll be one here, on where actually you're listening for the vascular sounds. It's a house-like formation. You start with the aorta and you work your way down. Percussion and tympany. Then you'll do percussion throughout the abdomen, and you're going to be listening for tympany and dullness. You're going to move clockwise around the abdominal area as you're listening. We're not going to measure the liver. So we're going to skip over this part. I think Debbie talks about it in her videos, but we're not doing that. We're also not doing liver span scratch test. You will listen for splenic dullness. If you actually hear a dull sound over the spleen, that probably means that the spleen is enlarged. And you're going to look at your costovertebral angle and see if there's any tenderness there. You're going to assess the kidney. You're going to place one hand on the back and you're going to thump it with your other, you're going to thump your hand with the other hand. Let's see, special procedures here, we're not doing those. Then you would palpate the surface and deep areas. So you begin by slowly palpating around the abdomen, and then you're going to go deeper using 2 hands around the abdomen. So as you start with light palpation, looking for pain and tenderness, any obvious masses, then you're going to go deeper, looking for pain and tenderness and obvious masses. If the patient is guarded or is experiencing any pain or tenderness, back off a little bit and determine where that pain actually is. So if you identify a mass, then you note the following: location, size, shape. What is the consistency? Is it smooth or nodular? Does it move? Does it move with respirations? Is there any pulse to it? Is there any tenderness? Here's just another reminder of the abdomen and where things are in it. Palpation of the liver, we are going to do that. So we'll show you how to do that. I think it's in Debbie's thing, but video, but I can also show you. And then you have to use a hooking technique to palpate the liver and the spleen. The only way to do that is to go behind, put your fingers behind the patient's back and lift the spleen forward. Then you're going to palpate the right kidney. You can't really palpate the left kidney very easily because of how they're positioned in the abdomen. if you can palpate them, your patient is either very thin or maybe they are enlarged. Then you're going to palpate the aorta. So that is a really cool thing. People don't realize how wide the aorta is, and you'll be able to feel that. And we're not doing advanced practice, but we do have to do Murphy's sign. And these other muscle tests here, we are not doing this. And I'm not going to do anything with the infant because you would not be doing that at your level of expertise or child. Aging adult, of course, you'll be doing a physical assessment on them. You're going to do it exactly the same way. You're just going to be careful because their skin wall is softer. Their muscles are not actually very intact. So you are not intact. Their muscles are weaker, so they're not going to provide a wall for you that's impenetrable. So know that you can just feel things a lot easier in an older person. And that, I think, is almost the end here. Abnormal findings. You might feel gas. You'll see ascites. Doubt that you would feel an ovarian cyst at your level. You certainly would be able to palpate a pregnancy. It's very common you might be able to palpate feces in the bowel or occasionally a tumor. You would be able to see or palpate an umbilical hernia, an epigastric hernia, an incisional hernia. And let's see. I don't know that would be something you guys would hear. Peritoneal friction rub, you're going to want to be looking for friction rubs. It's going to be something you're going to hear. Remember, friction rubs are like two pieces of leather being rubbed together. It's how the organs are actually rubbing together. You're going to be listening for bruits and a venous hum. And you're going to be assessing for enlarged liver, gallbladder. Well, you won't be necessarily being able to palpate a gallbladder, spleen, kidney, and aortic aneurysm. So here's your checklist. This is exactly what you're going to do, but you also have your checklist on your skills assessment that's much more detailed. And that's it. Thank you very much.